webinar on the subject of ureteral malignancies and obstruction management best practice sharing. My name is Indra from Teleflex Indonesia, and I'm joined with my colleagues from Teleflex, Haley from UK, and Joanna Lim from Singapore. Today, we are very pleased to invite 4 urologists to share their experience on the use of the RUS-DD ureteral tumor stent in their clinical practice. Before we start, I would like to invite Nico Volgarakis, the General Manager of Global Urology Care, to open this urology webinar with a small introduction to Teleflex Urology. Nico, over to you.
Thank you, Indra, and hello and welcome everyone to our first Teleflex Global Urology Care webinar. So thank you for taking the time to join us today virtually from around the globe. As Indra said, my name is Nico Vulgarijkis. I'm the General Manager for Global Urology Care at Teleflex. So the Teleflex Urology Care business unit designs health improvement solutions and offers urological products for users, caregivers, and healthcare professionals at hospitals and in the home care setting. Our urology product portfolio offers solutions for many applications. The RUS brand of urology products has a comprehensive line of bladder management solutions, including Foley catheters and urinary drainage systems, as well as products for operative urology and endourology. We believe at Teleflex that sharing best practices and continuously striving for excellence is a vital part of supporting our clinicians globally. So therefore today we have the honor of working with some exceptional clinical experts from the field of endourology who will present to you about ureteral malignancies and obstruction management and best practice sharing. So presenting today, we have 4 clinical experts in the field of endourology. That is Dr. Vidi Admoko, Dr. Shalawat Kosri Sirikul, Dr. Ananda Kumar Dhanasekaran, and Dr. Wai Ching. And I would like to thank you all for your support in preparing the content and presenting at this great webinar. So without further ado, please let me hand you back to Indra from Teleflex Indonesia, who will be going through some housekeeping, introducing our speakers and the topics they will be presenting today. Thank you. Indra, back to you.
Thank you, Nico, for your great opening speech. Before we start, I would like to go through some housekeeping items. If you have any question, please type them down in the Q&A box. Question will be taken at the end of 4th presentation. During the dedicated Q&A session, depending on the time, we may have to limit the number of questions answered during this session. We will be recording this webinar to allow us the capability to provide on-demand viewing in the future. The first speaker is Dr. Wei Xin, who is Deputy Chief Physician of Urology of West China Hospital of Sichuan, Secretary General of Upper Urinary Tract Repair Corporation Group, Urologist Branch, Chinese Medical Association. His topic is Diagnosis and Treatment Strategy of Malignant Ureteral Obstruction. So without any further ado, I would like to kick things off by welcoming Dr. Wei to start the first presentation. Dr. Wei, over to you.
Hi to you all. In this part, let me share our experience on diagnosis and treatment strategy of malignant urethral obstruction. Disclosures. In our view, tumor-associated urethral strictures can be divided into categories. One is caused by tumor invasion, compensation, and adhesion. Please note, and UTUC and other primary ureteral tumor are not included in this situation. Another type is treatment-related stricture, which could be attributed to the treatment of primary tumor, including surgery, radiation, and or chemotherapy. In general, the malignant strategies for these two types of urethral strictures are quite different. In regard to the first type, malignant urethral obstruction or stricture, our treatment aim is to get good drainage and good urine extraction, and to get the best therapeutic effects with minimal damage. The treatment principle is to minimize the impact on the ureter during the catheterization process. And our experience is no ureteroscopy, because the ureteroscopy may injure the ureter. No dilatation, the balloon may perforate the ureter. No laser, even with stones or neoplasma, because it's hard to be reached using ureteroscopy. If it's necessary, we may use a PCN channel. An operation under exterior intervention surgery is suggested. If retrograde catheterization is difficult, try PCN first and place the guidewire retrogradely. In most cases, placing a single in most cases, placing a single 6-French Russian tumor stent has been the best result, but the process is often not so smooth. Because this is a bilateral urethral image of a patient with gastric cancer. They had once only radiation therapy, the several urethral tortuosity on its right side become a superior shape. And the train to placement of the WT stent has failed without X-rays in the emergency department. This stent tip was twisted at the first tutoricity, and hydrolysis was not alleviated. Under the guidance of X-rays, the guidewire was successfully placed into the Urinary, and the hydrolysis was improved. On the left side of the patient is a repetitive canal malformation with separated urinary and varied degrees of hydrolysis. The stent was placed in the repeated ureter and urinary under the help of X-ray and assisted by arterography and flexible ureteroscopy. If we do not use X-ray, we can hardly find the repetitive canal and ureter. This case demonstrated that malignant urethral stricture should be safely performed under X-ray surveillance. Another case comes from a patient with urethral injuries who underwent open surgical repair and reconstruction. Under the observed endoscopy, two almost similar channels were found. Since the upper ends of two channels was almost closed, we could not judge which one was the real channel. With the combine of renal pairs and ureteral angiography, we finally determined that the right channel was correct. So with the help of X-rays, we can often find the right duct, which is very important. As a doctor, expectation for the urethral stent. We hope the tube has a certain headlace to provide strong axial circuits, improve urethral tortuosity, and it can prevent being passed shut with a strong radial support force, and it can be long retention time, and it should be easy installation. And the effects of the tumor biological behaviors on stent individuals' strategy. The stent are not suitable for rapidly growing tumors. For example, in some patients with advanced cervical cancer, 3 months after individual the stent, the tumor lead to viscovaginal fistula, and the stent prolapse through the vagina. Individual stent is not a good choice for tumors involving the bladder, especially for those with severe bleeding. So we have some contraindications to endovascular stenting, include the atresia, bleeding, neoplasma in the ureter, or severe infection, the bladder contracture, bladder dysfunction, or the fistula. In the case of the above situation or failure of stent individual direct, PCN is recommended. For urethral stricture associated with tumor, surgery and radio chemotherapies, our treatment target is different. For example, we would use 3 resistant individual stage to create a large channel and a long-term channel. Okay. Yes, actually, just try that. Here are some key points of our procedure. Number 1, to find the correct urinary luminal path. Number 2, build channels for suitable diameter. Number 3, choose a suitable stent for individual. Usually, we use the balloon to establish the channel. The channel created by the balloon should be usually less damaged to the ureter, and the lumen is relatively smooth. In this type of patients, stent quantities became more important. Treatment still requires good quality for urine. The stent determines the strategy effect, and the material, the structure, and the quantity determines the duration of the effect in dentation of the stent. Especially, malignant stenosis requires the stent with a strong support. In this case, the patient had multiple ureteral strictures and tortuosity by intravenous multi-stent. The hydrolysis of scandalis and the ureters was successfully solved. This is a patient. The middle and the lower ureter are strictures and failure lead to an acunar with the upper ureters, resulting in severe hydrolysis. We improved the tortuosity and adulation by using the Russian stent. Flawless hydrolysis were well relieved. And we have more case sharing. In this patient with in this patient with multiple stenosis, we usually place the guidewire artery wallet using the PCN channel. The guidewire goes in from the wrist, pass through the narrow anastomosis and come out from the inner outflow tract and to the body surface. I use the retrograde balloon dilatation along the guide wires to resolve ureteral stricture. And this is another case. In patients with complex bladder cancer with urethral reconstruction, the stenosis of the ureters often does not occur at the anastomosis, but elsewhere in the ureter. We steer treatment with balloon dilatations and multiple rush stent, which stent good therapeutic results was observed. So when we see stricture at here, and after dilatation, we may use more stent in the ureter. For this patient, ureteral venous fibrous compress the entire ureters, leading to hydrolysis. So multiple stents were replaced with units every year. In our experience, large proportions of our patients treated with stent could keep a suitable channel, and 1 year later, when we removed the J-tubule, the ureter was clear without hydrolysis. And this is a patient with ureteral peritoneal fibrosis. Bilateral ureteral compressing. The right side is local ureteral lumen stenosis. We need to use balloon dilatation to establish a good passage. The left stenosis is the left stenosis is a severe ureter tortuosity. We need to place the guide wire through these areas and use the appropriate support to maintain it. We placed 2 Ruchi stents on the right side and 3 Ruchi stents on the left. The bilateral ureters was unobstructed and no hydrolysis. In summer, while the drainage is unobstructed, the patient's post-operative comfort should also be considered. The surface materials and hardness of the stent itself, as well as whether it moves relative to the ureter, will affect the post-operative feelings of patients. So we have a conclusion: the treatment of ureteral malignant obstruction should be balanced. Low one step should be overheaded. The overall effect is the best. Okay, thank you.
Thank you, Dr. Wei, for your great sharing. Our second speaker is Dr. Sawawat Gosri Sirikul, Division of Urology, Department of Surgery, Rajapiti Hospital, Ministry of Public Health, Bangkok, Thailand. His topic is Ureteral Tumor Stent in Urology Practice. I would like to invite Dr. Sawawat to start his presentation. Dr. Sawawat, over to you.
Good afternoon. Thank you for introducing me to sharing the experience about the ureteral stent here today. Today my topic is ureteral tumor stent in urologic practice. The indication for ureteral stent, as we know, there is 2 points. The first is upper tract drainage when the ureteral obstruction. The second is prevent ureteral stricture after procedure, such as URS or such as ureterostomy. The pathology of malignant ureteral obstruction, as Dr. Wei Sin talked before here, is tumor invasion, extrinsic ureteral compression by the pelvic malignancy, or pelvic metastasis of the tumor outside the pelvis, such as breast cancer, gastric cancer, or pancreatic cancer, and retroperitoneal or pelvic lymphadenopathy. And the last one is consequence of treatment resulting retroperitoneal fibrosis or ureteral stricture, such as from radiation or from surgery. The therapeutic goal of urinary drainage in malignant disease, we need to think about 3 points. The first is adequate drainage of the upper tract to relieve the symptom such as pain or infection. The second is maintain the renal function and minimize further urologic intervention and length of stay, and improve the quality of life of the patient. The stent for malignant ureteral obstruction, there are many procedure or many types of upper urinary tract drainage, such as double J stent, the traditional stent, the metallic stent, tandem stents, that same as Dr. Wei, 2 stents in 1 ureter, and nephrostomy tube, the PCN, and the last one is extra anatomic stent to diversion the urine from the kidney outside the body and then go back to the bladder. But here, for the malignant ureteral obstruction, the metallic stents and PCN may be our first role. From the meta-analysis about the double J stent versus PCN in upper tract obstruction, but in acute upper tract obstruction from 7 trials and 667 patients. The conclusion is no significant difference between PCN and double J stent regarding the improvement in septic parameter or quality of life post-procedure. You can see some of the table from this meta-analysis. Double J stent improve sepsis than PCN, but not significantly. And double J stent has length of stay less than PCN, but significantly. But double J stent had more hematuria, dysuria, frequency urea than PCN group. This one is significantly. So how we choose for the patient? Here is the study to ask the patient choice about the method that they chose. They chose PCN or double J stent was influenced by the doctor. So if the doctor suggests them to do the double J stent, they choose double J stent. If the doctor said you should perform the PCN, the patient also choose PCN. But sometimes we cannot even do the double J stent. Here is my patient has prostate cancer with the bladder invasion and pelvic lymphadenopathy, and he got the renal failure. So I need to do the bilateral PCN and also need to do the open suprapubic cystotomy to drain some of the urine from the upper tract, because I cannot even do the cystoscope to the bladder. The advantage for the tumor stent actually should be drainage of the renal pelvis in severe obstruct ureter and severe obstruction by the tumor in case the high potential for traditional stent collapse. But the disadvantage for tumor stent is dysuria, fever, frequency, frank pain, and hematuria. Actually, it's same as traditional stent or same as the silicone stent, but the higher cost for the tumor stent. About my experience for the DD tumor stent, after I used this one from Teleflex, I think I'm familiar with it because it's easy to insert because the polyurethane with hydrogel coating. So I think it's the feeling when I put it into the ureter is the same as the silicone stent. And we can use the normal guidewire, the 0.035 inch PTFE guidewire. Actually, the guidewire can break by pull the inner stylet. And I follow up every 3 months to check about the position of the stent and function of the stent. And normally I change every 6 months, even if we can leave it for 1 year. So I do the same with the traditional stent. About the DD system here, I think maybe the advantage to adjust the the location of the stent. Sometimes when we push the stent inside, sometimes the pusher is in touch subsection with the double J stent, so we cannot advance it. And sometimes when we want to rushly to insert the double J stent, sometimes we advance the double J stent inside the UO. So if it happens, we need to use the URS to remove the double J stent. But here the DD system, if the guidewire inside, we can pull the double J stent out easily. And the inner lumen of the stent has the high resistance to collapse, around 4 to 5 times than normal stent. So my case example is 70X. It's 83 years old female with a CA cervix, status post radiation with the stricture ureter, and she was changing the double J stent every 6 months. But unfortunately, she got the coronary artery disease and status post PCI and stent 1 month ago. Now she continued the aspirin and Plavix. So you can see the CT scan, the double J stent still in place, but she had the hydronephriosis. So I think the stent, the normal stent may be not functioning. So I suggest her to change to the tumor stent. Here is my video about the experience to use the DD stent. Here is a hydrogel coating. I think it's very feeling hydrophilic. It's very easy to insert, and the guidewire can flex. So sometimes it's helpful to adjust the position of the double J stent. Here is the O stent. So I remove it first because I cannot pass the guidewire inside the lumen of the O stent. Here is the new stent, the tumor stent. And I insert under the fluoroscopic guidance to check the position of the double J stent. So when the double J is in place, I remove the guidewire here. After remove the guidewire, it's gonna disconnect about the DD system here. So it's easy to insert it to the bladder. We can see the urine came from the hole of the stent lumen. It's cloudy urine. So I think there is some obstruction of the O stent. So this is the old stent. So I don't tell about the which company, but when I peel the inside rumen, we can see the crop obstruction the rumen already. So it's not working. So my take-home message is what we choose the drainage for the patient is the first one is quality of life between modalities and about the side effect of urinary tract symptoms. And the last one is the cost of the modality, the cost of changing the double J stent or changing the PCN and hospitalization of the patient. Thank you.
Thank you, Dr. Sawawat, for your great sharing. Our third speaker is Dr. Widi Atmoko. Dr. Widi is medical staff in Cipto Mangunkusumo National General Hospital. He is head of Department of Urology Universitas Indonesia Hospital, Jakarta. Head of Information and Technology and Public Relations, Indonesian Urological Association. His topic is case study, the role of tumor stent in severe ureteral stenosis post-radiation therapy. I would like to invite Dr. Widi to start your presentation. Dr. Widi, over to you.
Thank you, Mr. Indra, for the good introduction. So I will share my screen. Okay. So can you see my screen, Mr. Indra? Yeah.
Can, Dr. Widi, thank you.
Okay. Yeah, good afternoon, everybody. Thank you so much for inviting me to this particular exciting masterclass about the tumor stent sponsored by Teleflex. The topic I will present today is the use of the tumor stent in managing severe ureteral stenosis post-radiation therapy. And this is my disclosure. And this is the outline of the presentation. We will begin with the sum of review radiation-induced the ureteral stricture and the problem with the common regular double G stent and the role of the tumor stent. And then I will present my case and I will close it with some take-home messages. So to determine the etiology, the obstruction is essential in planning the treatment approaches and estimating the prognosis. In general, the ureteric obstruction can be divided into benign and the malignant ureteric obstruction. The ureteral stenosis post-radiation therapy is included in benign causes, whereas those due to the intrinsic or the extrinsic obstruction due to tumor mass is included in the malignant obstruction. So in this slide, we can see that the radiation-induced ureteral strictures is first reported as a complication in 1920. And since then, the several other publications confirm the finding. It is most commonly seen in radiotherapy due to the prostate cancer, the cervical cancer, and also the retroperitoneal sarcoma. The risk may depend on the dose, mode of the delivery, and the type of the cancer. But one thing to put in mind, it can present as a complication up more than 25 years post-radiation with an increase of 0.15% incidence per year. And it is confirmed by the research of more than 1,700 patients we can see from the right side with the cervical cancer stage 1B treated with the radiotherapy. And not only the radiation, but the combination of the radiation and surgical treatment carries a higher risk of the ureteral stricture complication. As shown here, the 10-year propensity weighted cumulative study of the ureteral stricture in more than 114,000 of the prostate cancer patients is higher on those who receive the combination treatment, with the highest up to 27% in group treated with the radical prostatectomy and the EBRT. And the postulated mechanism that explain the pathophysiology ureteral stricture post-radiation may include the pronounced the desmoplastic reaction and then increase the sensitivity due to the infection, the necrosis of tumor that followed by the fibrosis, or the direct radiation injury on blood supply. And all of this will result in fibroblast proliferation with less regenerative capacity and led to the difficulty in management. So the goal in managing the radiation-induced urethral stricture is basically similar to another general urethral obstruction, which includes the urine drainage and to maintain the renal function, to minimizing the intervention and improving the quality of life with some consideration includes the clinician expertise, the procedure availability, and also the urgency of the diversion. And however, compared to other urethral obstruction, the radiation-induced urethral stricture is relatively more challenging, as it is tend to be long, bilateral, and also ischemic. Several management options that we can do includes the endoscopic and surgical management, as shown here. However, we will focus on urethral stent and also the nephrostomy. So, if we compare the nephrostomy and the stent, generally used as the temporizing measures until the definitive repair, but they may be a long-term option for the patients that not amenable for the surgery. And the double J urethral stents generally represent a more appealing drainage option, as the nephrostomy tubes carry the inconvenience of an external urine bag. However, as many as maybe 50% of the urethral stents placed to treat more complex urethral obstruction, such as malignancy urethral obstruction, or because of the radiation-induced urethral stricture, often within weeks. If we take a look at this report on 202 patients with a cervical cancer patient with the medial follow-up of 2.5 years, up to more than 58% subjects has more than one time ureteric stent procedure, with the proportion higher in those who received the radiation therapy as seen on the graph. And the result also confirmed by the retrospective analysis as shown here, which result that the patient with the history of the radiation therapy has significantly lowered the ureter stent patency rate for only 50% compared to non-radiated group up to 92%. And the problem with the managing radiation-induced urethral stricture with the regular stent is that the adequate insertion doesn't guarantee renal decompression. Other than that, the regular double G stent need to be replaced for 3 until 6 months and prone to things such as the incrustation, the obstruction, the migration, and fracture, and high failure rate. In radiation-induced urethral stricture, endoscopic insertion of the urethral stents may be difficult or even impossible due to the compression or because the scarring of the ureter was too severe. And most double G stents have tendency to malfunction in less than 1 year and more prone in metastatic cancer who require chemo or radiotherapy. And several predictors of the failure in stent placement includes of old age, the moderate and severe hydronephrosis, the pre-existing pyuria, and lower ureter obstruction. The failure criteria includes the hydronephrosis upgrade, the serum creatinine increase, and then the nephrostomy insertion, and also the clinical significant symptoms. So it is important for us to use a more appropriate stent in all cases. It should be emphasized that the ideal stent drainage for the urethral obstruction should take into consideration is stent patency, the patient quality of life, the frequency of stent exchange, and associated costs that are influenced by stent size and composition. A better design would include high degree of the stiffness, the wide inner diameter, and also the adequate length of the stent. And we can see from this slide that there are several stent materials that can be used for the stent materials, which include the metal, the polymeric, the biodegradable, and many more. And tumor stent is generally reinforced at the middle using other stronger materials. So these are some examples for the metallic stent, the left one, and the traditional polymer-based stent in the middle, and also the more evolution, the reinforced or the polymer-based tumor stent. And this is a study comparing the metallic stent to the traditional polymeric stent, and it shows that the patency rate was significantly better for the metallic stent compared to the standard traditional polymeric stent. And what about the metallic stent versus the new technology with the polymer-based tumor stent? The difference between these two is that the metallic stent generally have longer period to be left in situ, up to 1 year, and it also results in reduced incrustation and improve the tensile strength and the stability, prolong the stent indwelling time, and better flow. However, most metal stents have the occluded ends, unlike the usual polymeric stents, so making the replacement and exchange slightly more challenging than a traditional stent and need the fluoroscopy guidance. Whereas the advantages of the polymer tumor stent is that it can be inserted without the fluoroscopy guidance if we don't have it, and even in SuperGlide with the DD coupling made it easier for the maneuver during the placement. But up until now, there is no universal indication, but mostly used in severe obstruction due to external compression or not favor the frequent replacement. Unfortunately, the study is very limited to compare the metallic and the polymeric based tumor stent, and also the further RCT is needed. We only know that the radiation exposure is higher in the metallic stent placement, and there is also one study in Taiwan that reported that the cost of the metallic stent is 4 times higher than ureteral tumor stent. So if we take a look at the in vitro study of the tumor stent as shown in the picture, the to replicate the tumor radial compression on reinforced urethral stent and water flow rate plus energy forces was measured in this study. So they used the teleflex tumor stents, the BART, and then also the coloplast stent. So the result shows that some urethral tumor stent, as shown on the red box, the wider the diameter helped to increase the volumetric flow rate, but didn't affect the stiffness of the stent, so it can go against the compression force. However, some other stents, such as the number is P8 and the P7, has shows that the increase of the diameter may lead to decrease of the stiffness. So the characteristic of the stent is really depends on each type of the stent. And from this study, we also see that the teleflex 8 frank, especially in tandem stent, obtain the best result against the radial compression. This is the P8 is the teleflex 8 frank tumor stent compared to another stent which has another branch. And what about the in vivo study? Unfortunately, there is not yet a specific study that explains the efficacy of tumor stent for the radiation-induced urethral obstruction. However, in this study, comprising 150 patients with 55 procedures in patients with the malignancy obstruction of the ureter, it can be seen that the SuperGlide and the Tandem Stance were the best stents against stent failure. And lumen and the stiffness of the stent have been shown to be critical factors in controlling patency as SuperGlide, and the Tandem Stent had the highest stiffness and the biggest lumen. And another study, a non-comparative study of the polymer-based reinforced stent, it shows that the polymer-based tumor stent is an efficient option which could improve the obstructive uropathy in about 60% of the patient and maintain about 6.8 months in average. Along with the previous study, the Tandem Stent, which is maybe from Dr. Wei, present the case and may be chosen as an alternative in a case where high patency is needed. However, the placement of 2 parallel stents may be difficult technically and can worsen the stent morbidity. And one retrospective study of 62 patients with reinforced stent for the malignancy obstruction of the ureter shows that the tandem reinforced stent result in lower rate of the obstruction, which is 11%. And so the obstruction of the stiffest stent in less than 6 months motivated the switch to the 8 tandem stents. And one retrospective study, so we conclude that if there is an obstruction of the stiffest stent in less than 6 months, we have to educate the patient to switch to 8F tandem stents in this study. And this is my case presentation that I have experienced. So this is the case we will discuss today. It was a male, 84 years old, and he was admitted to the hospital due to fever and foul-smelling urine since 1 week prior to the hospital. The patient was on indwelling catheter and bilateral double G stent in another hospital before meet me. And this is the history of the patient. The patient on 2010, he was diagnosed with the prostate cancer and underwent radiotherapy for 27 times and now in remission. On 2015, the patient had stroke with the history of the uncontrolled hypertension. Later on, 2018, he was diagnosed with the bilateral kidney stone and underwent RIRS with another urologist. As the patient showed the urethral stenosis, the procedure also includes the bilateral double G stent insertion. Noted that he used the normal polymer double G stent in this case. And until 2021, the double G stent has been replaced for 3 times. And the patient also used the urinary catheter since 2019 due to the unable to urinate spontaneously and because the patient is immobile. And from the physical examination, the vital sign was stable, but the patient was in not good convulsion state. And another physical examination was unremarkable. Aside from the genital was on silicone Foley catheter size 18 Frank with the production of the cloudy urine. And the lab result indication, we can see that there is a decrease in renal function with the high infection, with the high CRP and procalcitonin, with the urinalysis and the urine culture confirmed the urinary tract infection. And from the ultrasonography, we found that there is a grade 3 bilateral hydronephrosis. And the patient were diagnosed with the urosepsis and the acute chronic kidney disease and bilateral hydronephrosis. So the patient was done nephrostomy, bilateral nephrostomy on the next day with me, and the procedure was very good. And he was hospitalized for 13 days, and he discharged with the improved renal function, the level of creatinine, which is 3.6. And the patient came to my clinic for the follow-up on June, and he had no complaint, but the creatinine increased again to 44.4. And he was then planned for a tumor stent placement on August because the patient and the family asked to remove the nephrostomy. And on August, the patient underwent the cystoscopy with the bilateral RPG and bilateral double G stent and nephrostomy replacement. The operative report as follows: the double G stent placement for the right ureteric side was good, no problem. And however, for the left renal, we have to do the optic dilatation as needed because there was a partial stenosis on distal ureter that made the cobra wire cannot pass the ureter. And this is the C-arm view that the nephrostomy and the stent had placed successfully. And we can see that there is some not good contrast descending from the kidney because the ureter is very, very stricted here, bilateral. And this is the endoscopic view. So please note that there is this is the old double G stent, the normal polymeric stent, which the size is 4.7 Frank. And then we can see that from these photos that there is a partial stenosis of the left distal ureter at sacrum 1 by fibrotic tissue. And then we successfully insert the double G stent with the tumor stent. Actually, before we insert the tumor stent, I try with the standard stent with this kind of the stent, but it cannot advance. But after that, we use the tumor stent from the Teleflex. We successfully inserted with the bilateral ureter here in this case. And 2 days after the procedure, the urine production per nephrostomy was good, and the renal function was improved with the creatinine level 2.9. And during follow-up on November, the patient's family started his concern on the external device from the nephrostomy and asked the possibility to remove it and leave the patient with the double G stent only. And the patient was then asked to clamp the nephrostomy tube for 1 month to see the urine production per urethra, to see the stent patency. And on the November, the nephrostomy had clamped for 1 month, and the urine production per urethra was good, which is 2,000 milliliter per day. Before we clamp the catheter, usually there is no urine production in the urethral catheter. But after we try to clamp the nephrostomy, the production is very good with the urethral catheter. So it make showing a good potential of the stent. And then the nephrostomy was then removed. And if we take a look at the bilateral antegrade pyelography, which is we did it before we removed the nephrostomy, so we can see that the contrast didn't appear to fill the ureter around the double G stent. We can see that this is the left antegrade pyelography. The contrast is filled the PCS, but the contrast didn't fill around the ureter, but the contrast is filled the bladder, if we can see from this photo. Also from the right kidney, also the contrast is filled the ureter, the PCS, but again in the distal part of the ureter, the right ureter, the contrast didn't fill around the ureter, but still the contrast filled passing the contrast into the bladder. So we can see that the double G stent, it shows that had a good patency. And then the post-nephrostomy removal, the ultrasonography was done, and the grade 1 hydronephrosis was still found on the right side. But another ultrasonography examination was done 2 days later after the observation, and no hydronephrosis was found on the both kidney. And this is the summary or the highlights of the case. Note that the creatinine decreased after the tumor stent placement, and the patient also had good urine production per urethra after the nephrostomy removal on the November 2021. So the lesson learned from this case is that the radiotherapy may result in urethral stenosis even after the long term. In this case, it's about 20 years. And the patient also had RIRS, so maybe there is a two-hit hypothesis may explain the development of the stricture in this case. The first one is because of the radiotherapy, and the second one is about because of the urethral manipulation during the RIRS. And as for the management on patient with the urethral stenosis post-radiation therapy and the several predictor of the stent failure, which is old, severe hydronephrosis, cancer, and pyuria, the tumor stent is effective and safe. So as a take-home message, to release the obstructions from the radiation-induced urethral stricture is generally more difficult. The double G stent can be used as short or long-term management, but the failure rate is high. And the stiffness and the wide lumen is necessary for the stent patency. The urethral tumor stent can be an alternative for these complex cases, and the data shows its effectiveness. And the Tandem Stance should further be considered in patients with failure stent. As there is still minimum comparative data, the long-term clinical trial is needed to confirm the benefit of the tumor stent compared to another stent such as the metallic stent. So that's all from me, and thank you very much for listening to my talk. I will give back to Mr. Indra. Thank you.
Thank you, Dr. Widi, for your great sharing. Our fourth speaker is Dr. Ananda Kumar Danasekaran. Dr. Dana Sekaran is urology consultant and deputy head of academy in Sunwell and West Birmingham Hospital, NHS Trust in the UK, and deputy head of academy in Sunwell and West Birmingham. His topic is case study, current clinical rationale for using the RUS DD tumor stent, tip and tricks. I would like to invite Dr. Dana Sekaran to start your presentation. Dr. Dana Sekaran, over to you.
Thank you very much. Thank you for the introduction. I thoroughly enjoyed the previous three speakers. I will try my best to avoid unnecessary overlap with the previous speakers and try to see how far I can take it into the tips and tricks and the role of the Teleflex DD tumor stents. This is my disclosure. So we have already discussed quite in detail the indications for the stent, both in the malignant situations and also the normal scenarios like stone treatment, ureteroscopy, etc. The main problem with the stent is the side effects. Like for example, the stent can cause ureteric reflux, which can cause pain in the loin, and also especially in this tumor situation, we have failure of the stent because the tumor ingrowth into the ureter and also compressing the stents. Normal polyurethane stents, because of the multiple eyes throughout the stent, are much more prone to obstruction, while tumor DD stents from Teleflex is having no eyes. They have eyes only in the J component of the pelvis and the bladder. The main challenges we face when we keep a stent is overshooting, by which the stent has passed the VUJ and lower end is present in the lower ureter, or excess of stent getting crawled in the bladder, which can cause storage symptoms by irritating the trigone and the bladder mucosa. Both these problems can be circumvented by using the tumor stent because of the DD technique, which is directable and also detachable. So the tumor stents has the properties of DD coupling, which I has mentioned, directable and detachable. It has got super glide coating. This makes the placement of stent easy, and also it passes through the stricturous element easily. It is a reinforced stent. Because of that, the chances of compression is rare. I will go through the clinical benefits of the tumor stent also. So this is how the DD coupling works. The stent and the stent pusher are coupled by a mechanism, as you see here, and once the guide wire passes outside into the pusher, the DD coupling uncouples. So the surgeon has a full control on when the stent should be released. If there is a need, we can redirect the stent to the upper pole, or in case if the kidney has two pelvic alysis systems like superior or inferior, we can direct the stent into the upper or lower pelvic alysis system. So the surgeon will have excellent control of the lower end, and also it is directable in the upper end. I will take you through one of my patient. She is an unfortunate 55-year-old lady with lymphoma. She presented with extensive retroperitoneal lymph nodes causing obstruction of the right ureter at the level of the L5 vertebra. Here patient is lying on prone, hence the right kidney is seen as if on the left side. The antegrade nephrostomy has shown hydroureteral nephrosis extending up to the L5 vertebral level. She presented with a previous stent placed in another hospital. Unfortunately, the stent is heavily encrusted and not functioning. This is the CT scan picture showing the right side hydronephrosis, both sagittal and coronal plane. This video will explain the mechanism by which the tumor stent works. So, as we all know, tumor stent comes in a package. The package consists of a guide wire, stent, and a complete assembly. It's very important that the surgeon is quite confident in the parts of the tumor stent, and he should be able to use the elements quite successfully. So we need a scope to pass the guide wire and stent. The stent has got special markings. I will discuss that further in detail. This is the DD stent with the assembling of the pusher, and we got a clamp to hold the guide wire against the patient's drape if needed. All the stents are attached with a patient card, which is quite useful when the patient needs to take the details of the stent which he had underwent. The speciality of the tumor stent is this special braided stainless steel embedded into the wall. I will go through this more in detail. As you can see, the stent shaft is made up of braided stainless steel and it is highly resistant to collapse. The inner lumen is not compressible. That's why we are getting the excellent results with the tumor stent. So this is how the DD coupling mechanism works. As soon as the guide wire is moved into the pusher, the DD coupling will get uncoupled. It comes with a pre-fit covering. This covering should not be removed till the time when we are planning to proceed the procedure. The guide wire is also quite special. It has 4 markings. The 4 markings help us to decide when we are planning to release the JJ stent. In the 4th marking, the stent will be automatically released. So as soon as we are reaching the 2nd or 3rd marking, we should be comfortable with the upper end. We should be comfortable with the bladder segment also. In this animation, you can see the kidney on the left side is blocked by the tumor. Because of that, there is hydronephrosis and urine is just trickling down and it clearly shows a blockage. So patient needs a tumor stent placement. It easily can be done by a rigid cystoscopy or a flexible cystoscopy. Here we are using flexible cystoscopy, make a good examination of the bladder to make sure there is no further recurrence in the bladder. And I prefer to use the guide wire which is coming already in the package itself. And as the guide wire is going in with the help of the image intensifier, you can easily place the guide wire in the pelvic alysial system. The guide wire has an inner movable core, which I will discuss further in the future slides. Once the guide wire is nicely placed, you can upload the tumor stent, and once the guide wire passed the DD coupling element, the sheath can be removed. As you can see that the guide wire placement and the stent placement can be continuously monitored both optically in the bladder and also with the help of image intensifier in the kidneys. As soon as the first marking, a separate 1 marking, has reached, you can assume that the upper renal segment is going to get released. And then once we get the 4 marking segment, the bladder segment will get released. So this gives the surgeon absolute confidence in both the release of the upper kidney J segment and also the bladder J segment. Thus, I find that this tumor stent with its intelligent guide wire system with special markings help us to place the guide wire and place the tumor stent in an appropriate manner. The surgeon will have absolute control over the positioning of the stent from the starting to the end. This study is already quoted by the previous speaker. Vogt B has done an in vitro study comparing the Teleflex 8 French, 7 French, 6 French and also Tandem Stance in comparison with the stents from the other brands. It's quite clearly proven that by a big margin, the Teleflex 8 French Tandem Stents are much better in maintaining the stiffness, maintaining non-compressibility and the urine drainage. Now I will take you through some important tips and advantages present in this particular tumor stent. As I said, the guide wire of the tumor stent has got an inner movable core. When the movable core is nicely fit into the guide wire, The tip of the guide wire will be quite stiff and it can be used as a straight guide wire. In case if you feel that the straight guide wire is not getting into the stricturous element, you can remove the inner core little bit. That makes the tip of the guide wire very flexible and malleable. This kind of modifiable guide wire you can't see in any other tumor stent or any other branded polyurethane stents. The advantage of this malleable tip is now the tip becomes almost like a J-tip guide wire. So your maneuverability into the tumorous stricturous element is bit comfortable. Once you pass the stricture element, you can replace the inner core back so that the tip of the guide wire will regain its strength and the tip will become more stiff. So the surgeon has full control over the stiffness of the guide wire, which you can't come across in other brands. And then the another interesting and intelligent part of this tumor stent system is the guidewire markings. The guidewire has a single mark. As I said, the single mark gives us an idea that the J segment in the kidney is going to be released, which of course you can see with your image intensifier also. Then we got the 4 marking systems, and the 4 marking systems gives us the full control on when you want to release the guide wire, when you want to make the stent decoupling, and how much of segment you want to leave it in the bladder. Less segment in the bladder, less irritation to the trigone and the bladder mucosa, patient will be comfortable. All these stents are licensed to stay for 12 months, so we don't want the patient to suffer with the stent related symptoms. Before using the DD coupling, make sure that the guide wire is passed nicely beyond the DD coupling area, because the DD coupling will be intact as long as the guide wire is inside or the outer sheath is kept intact. As a last step before you want to install the stent into the system, the assembly aid can be removed. The assembly aid just holding the DD coupling intact as long as you wish. The assembly aid is very good both in the transport and also inadvertent removal or dislodgement of the DD coupling just before you are placing the catheter. As I said, once the assembly aid is removed, you need to make sure that the guide wire is inside, otherwise the DD coupling will get disconnected. As I mentioned, the 4 markings are very intelligently placed. When you have the first marker, you can be sure that there is 3 cm to go before the DD coupling is going to get released. When there is 2 markers on the cystoscope end, there is 2 centimeters to go. And when you have the 3rd marker, it means there is 1 centimeter to go. So when you have these markings, you can decide whether you are happy to dislodge the DD coupling or you want to maneuver it further, whether you want to have less amount of segment in the bladder or you want to direct the stent upper end into one of the calyces. So you can do all the maneuvers before the DD coupling releases itself. And once you have the 4th marking, the DD coupling will get released and you will have a successful placement of the JJ stent. So in my view, the advantage of the tumor stent is not only in the robustness of the stainless steel braided non-compressible wall of the stent, and also the intelligent way by which the guide wire and the DD coupling mechanism helps us so that we can keep the stent in a very comfortable, patient-friendly manner without much of the bladder irritation. The stent is directable in case of difficult situations. As I said, if there is a bifid ureter, you can direct the stent into the upper or lower moiety as you need. It is disconnectable when appropriate. Teleflex 8 French stents kept in tandem fashion is the best available in this time for an appropriate deobstruction of the tumor obstructed ureters. There is no ice in the stent, as I said, which is very important. Presence of ice can result in the ingrowth of the tumor and create blockage. The stents are reinforced. Those who are well versed in placing the stenting, there is no specific learning curve in this DD coupling mechanism. All you need is to use the DD coupling few times to get used to that and use every aspect of the stent mechanism. Thank you very much.
Thank you, Dr. Dana Sekaran, for your great sharing. For our Q&A session, I would like to hand you over to Joanna Lim, the Senior Clinical Manager, to moderate this session. Joanna, over to you.
Thank you, Indra. Hi, everyone. I'm Joanna. And first of all, I would like to take this time to appreciate our 4 speakers for this really detailed explanation, case studies, sharing of their experience on the use of the urethral stents in their practice. And we have, our speakers are from around the world, from the UK, from Indonesia, from Thailand, and from China. And being able to learn from their experience, their practice, their cases, gives us a bigger understanding of, these procedures. So our 4 speakers, if you could put yourselves, open your cameras, that would be great, so that we can start the Q&A session. So looking at our participants, we have a lot of participants from around the world as well, from Europe, from Asia Pacific countries. And we do have some questions for the specific doctors. So maybe let's start with the first question. And for the participants, if you have any questions at this point, feel free to type it also in the Q&A box below. You can see it on the screen. It's right below Q&A. Type in whatever questions you have. We have about 10 to 15 minutes to answer the questions that you may have. Okay, so maybe let's start with Dr. Wei. And I know Dr. Wei is still in his clinical practice. He's still attending cases. So really thank you for taking your time out to be with us at this session. So maybe we will not understand a little bit from Dr. Wei. He's from Sichuan, the China West Hospital. How many strictures or how many patients with strictures do you see every month, and how many of these cases that you see are of malignant stenosis?
There are about 30 tumor-associated strictures in the West China hospital every month. And among them, there are about 5 strictures due to compression or invasion of the ureter. And the rest were strictures due to radiations for the pelvic malignancy. And I hope this answer can solve your problem.
Thank you. And what do you think, Dr. Wei, what do you think is the ideal stents for patients with stenosis? Is there an ideal stent, in your opinion?
As we mentioned in our presentation, we think ideal ureteral stents should have the following characteristics. First, have a long enduring time. Second, ureteral stents should be easy to place. Third, we hope the stents can improve the tortuosity of the ureter.
Yes, thank you, Dr. Wei. Okay, maybe I will hand the next question over to Dr. Ananda. So Dr. Ananda, you gave us a lot of details, a lot of guidance on the DD coupling feature of this tumor stents. So how do you decide on which stent to use in terms of patients with this ureteral strictures? When do you use a tumor stent, and when do you use a normal double J stent?
In a patient with ureteric stricture due to a tumor, we need to use always a specialist stent. The reason why we have to use a specialist stent is, number one, the patient needs a stent for longer than the normal duration. Say, for example, after ureteroscopy and laser lithotripsy for a stone, you need to keep the stent maximum for a week or if not 2 weeks, while the patients with tumor, they are going to have the stents for months and months. So you need to have a specialized tumor stent. I'm happy with the Teleflex Rush DD coupling stent because they are licensed for 12 months. That makes the patient to have the stent change in a risk frequent manner, less need for anesthesia. As I mentioned, much more advantages of the Teleflex 8 French and 7 French stents are the DD coupling mechanism, which helps us to keep the stent in an appropriate position. I like to keep the bladder part of the stent as minimum as possible because that segment is the one which irritates the bladder and creates the storage urinary symptoms like frequency and nighttime frequency of urination. So tumor stent, especially the Teleflex 8 French or 7 French stents are very ideal, but the patients who had good capacity in the ureter, a tandem stent is a much more better choice.
You mentioned about tandem stent because that's the next thing I want to mention. I want to ask you about. So maybe I would ask all four physicians, but I'll start with you, Dr. Ananda. Talking about tandem stents, how often does that happen? And if that happens, is there any specific cases that you would choose a tandem stent over a normal, just one stent?
Always tandem stents are slightly better in the drainage because as we know the stents drain more in the peristent area rather than through the stent. So obviously when you're keeping a tandem stent, it creates a nice H-shaped groove outside the tandem stent assembly that gives us an excellent opportunity to have a good peri-stent drainage. But placing of tandem stent is not very easy and it all depends upon the individual patient's ureter anatomy also. We may have to keep 8 French stent and then maybe in the next stent change we need to use some balloon dilators to make the patient's ureter capacity enough to have a tandem stent. If you're keeping a tandem stent, even a 6 French tandem stent is not a bad choice. So whenever a patient is subjected to have a long-term ureteric stent because of irreversible malignant situations, the gold standard is 8 French tandem stent, which is also proved by the studies which both me and Dr. VD has shown in the in vitro studies. But when it is not possible, try to go for the best possible tandem stent like 6 French or 7 French. If it's not possible, go for a single stent and plan for tandem stent on a later date.
Thanks for that. So maybe I will ask Dr. Weedy next because you also mentioned about the tandem stents in your presentation. So in your practice, in your experience, how often does that happen?
Yeah, thank you, Ms. Joanna. And I agree also with Dr. Ananda based on the evidence. The point is the tandem stent is very good compared to another stent. But we have to know that the placement is maybe difficult and maybe if the size of the ureter is very, very small, I think at least one stent is enough. But because of the Teleflex stent, I think it's very good in the middle part of the WG stent. So it's very, they have the reinforced stents and then the stiffness is okay, is very good. And if the passage is still good and then we can evaluate the function of the renal is good and then there is no hydronephrosis with the follow-up study, I think it's good for one stent. But in the beginning, if we see that maybe the ureter is a little bit large but the patient had the tumor or the malignancy cases with the next plan is the radiation therapy, maybe they plan for another, they still have the radiation therapy for the next week or month. Maybe we have to put the tandem stents to make sure that the ureter is good for the long time. So I think that's my plan when we want to use the tandem stents.
And can the tandem stent be kept in the patient for a long time? If it is, how long would you, in your experience, have you kept it in for?
Still, we can use as long as we need that, maybe for 1 year. Yeah, six months and until 1 year.
Great, thanks, Dr. Weedy.
Yeah.
Right, we have another question from the participants for Dr. Chawawat. Does tumor stent has any advantages for extrinsic obstruction, for example, ovarian cancer, if compared to the common double J stents?
Actually, yes, because the inside lumen has the coil inside that it actually very stronger than normal strain, around 4 to 5 times.
Mm-hmm.
So I think actually for intrinsic obstruction maybe use the tumor stent, and if the failure of stent, maybe we move on tandem stem or another choice of drainage. Sometimes if fail of the internal drainage, maybe outer drainage like PCN is okay, or sometimes if we treatment about the cancer already and the cancer already subside, we can do the operation such as reimplantation or some substitute of the ureter. But normally, I think there is advantage for the tumor stent than normal stent in the intrinsic obstruction.
Great, thank you. And how do you decide which stent to use? Which size of, I'm sorry, how do you decide which size of stent to use for each procedure?
Normally, in Thailand, we use 6 French of the stent, the normal stent. And for the tumor stent, we use 7 French of the tumor stent, because we only have this size, and it's easy to pass it by local anesthesia. So if we want to try the tandem stent, that egg frame with two stent inside, we need to dilate the ureter. So it's not easy to use the tandem stent, even if they can absorb the pressure, the base of absorb of the pressure. But normally we use 6 and 7 French of the tumor stent.
Okay, thank you, Dr. Chawat. So I think we have come to almost to the end of our Q&A. Maybe I would like to take this time to go through with each and every one of the presenters, just to give a summary of your discussion and also your opinion of what can be done more in the future. Maybe we'll start with Dr. Wei. It's possible that Dr. Wei has to go back to his clinical practice. So maybe Dr. Chawawat?
Me, maybe we need to see about case by case, because sometimes we cannot insert double J stent. So sometimes we need to see the how to drainage the upper tract, maybe PCN or double J stent or tumor stent, because sometimes we cannot use tumor stent in every case of the malignant, because sometimes it's higher cost than normal stent. We need to adjust case by case, for my opinion.
Thank you, Dr. Chawat. Really appreciate it. Okay, how about Dr. Weedy? Any final advice that you have for our participants?
Yeah, I also agree with Dr. Chawat. We should individualize with the case of the patient, case by case. But the message is the double G stent can be used as the short and the long term of the management of the urethral stricture, but we should see maybe to evaluate whether the double G stent is adequate or not. And I also agree with Dr. Ananda that if the case is a tumor stent, and if the patient maybe from the cause is not, it's okay, but for the cause, but I think it's the first choice. We should use the tumor stent, and also we should use maybe the bigger is the better, but depending on the size of the ureter, because we know that the bigger size is proven to be the good, better drainage compared with the smaller size. I think that's all from me, Ms. Joanna.
Agree. Thank you so much, Dr. Weedy. Really appreciate it. And finally, over to you, Dr. Ananda.
Thank you, Joanna. My main take-home message is these patients which we are discussing are very unfortunate, and they have their own primary diagnosis of cancer, which could be like a gynecological in origin or lymphoma, like one of my patient, or primary urological cancer. So we don't want to increase the burden of the patient by putting them on a stent, which also going to produce more stent symptoms, sleepless nights, etc. So I wish the participants to learn the technique and also the advantage of the Teleflex tumor stent. Number one, it is quite robust and it is nicely braided and it is not compressible. And also try to use the DD coupling technique and also the markers in the guide wire, which is coming in the package, so that you can give an excellent care to the patient. It gives so much of confidence to the urologist that he is able to place the guide wire and the stent with so much of confidence. I've come across few situations where the upper ureter has got bifid pelvic calyxal system, while one calyx is not that hydronephrotic, so we wish to keep the stent on the real blocked hydronephrotic system. The directability of this tumor stent is very handy, and the detachability at the time when we need gives us the confidence that we are keeping the stent in an appropriate position. It prevents overshooting and also it prevents unnecessary too much of segment in the bladder. The time taken during the stent placement, say maybe like 15 minutes, 20 minutes in the stent placement, if it is placed appropriately, that is going to give the symptom-free life for the patient for the next 1 year. So the surgeon should keep that in mind and learn the techniques by maybe going through this video again and give an appropriate service to our patients. That's my take-home message.
Thank you, Dr. Ananda. You raised up a very good point, important point, by putting the patient in the center of what we do, keeping them in mind when we choose our procedure, choose our products that we are going to do on the procedure on them. So thank you very much for your time again. And this will conclude the end of the Q&A. I will hand the time back to Hayley to conclude the session. Thank you very much.
Thank you, everyone. Thank you, Joanna, and thank you to our guest speakers. I'd like to echo the appreciation to our guest speakers for taking time out of their really busy schedules and sharing with us all your clinical knowledge, your experience in enlightening us on such an interesting topic of management of ureteral malignancies and obstruction management, and also especially for the information you've given us with regards to how beneficial our Ruche tumor stent is too. Thank you so much to each of you. I'd like also to thank our global urology care team for supporting today's event, and also to all the team that were involved in the organisation of this webinar. They've worked really hard to make this event really successful, so thank you to that. To all of our audience from around the globe today, thank you so much for your attention and asking some really thought-provoking questions. We hope this webinar has really supported the delivery of excellent healthcare to patients with ureteral malignancies. At Teleflex, our aim is always to support the sharing of best practice and to strive for excellence. And we really hope you will join us for future educational webinars and content in 2022. I want to close this webinar today by wishing you all a very happy and healthy, prosperous New Year and Christmas. And from our Teleflex Global Urology team, thank you so much for your attention, and all of you take care, and we will hopefully see you in 2022. Thank you.
Thank you, everyone.
Thank you very much. I thoroughly enjoyed the meeting. Thank you for all the hard work.
Merry Christmas. Happy New
Thank you,
Year.
everyone.
Happy New Year
Thank
to
you,
everyone.
everyone.
Bye-bye all.
Thank you, everyone.
Thank you, everyone. Bye bye.